Welcome back to Falcon Physician Review's online review for USMLE Step 1. This is Module 36, where we'll talk about arboviruses. Arboviruses have a family of zoonoses, where these are viruses which live inside different animals, get transferred to us from different insect vectors, and cause human disease. There's a lot of them. They're not very clinically distinguishable, and it'll be a list of things which you can memorize. Fortunately, they don't show up very frequently on USMLE Step 1, and so knowing the few key things we'll go through in this module will help you to score higher and get the test results that you want. Welcome to Falcon Physician Review's online review for USMLE Step 1. This is Microbiology, Module 36. We're going to talk about arboviruses. This table helps you organize your thinking about arboviruses. They are zoonotic viruses that are transmissible from animals to man. We'll talk about toga viruses, flaviviruses, bunyaviruses, and rheoviruses. You have to remember that rotavirus and Colorado tick fever virus are also zoonotic. The diagnosis often depends on IgM serology on serum and CSF. 40% of these have detectable IgM by CSF by day 4. By day 10, some people are nearly 100% positive. If you can find IgM in the CSF, that'll be diagnostic. Serum IgM is a presumptive, as antibody can persist for up to 1 year in serum. Cross-reactivity is also positive with St. Louis encephalitis virus and West Nile virus. Diseases caused by arbovirus include encephalitis, febrile diseases, and hemorrhagic fevers. The transmission is often mosquito-borne. We don't really have any specific treatment, and travel history can be important in finding out which virus is involved. You'll have a figure here that describes a life cycle, which is also called the sylvatic cycle. You have basically your vertebrates which change as hosts between arthropods. The arthropod will be infected from one vertebrate, transfer it to another, then you get it back to the arthropod, and the arthropod is what gives us to us. In the urban cycle, you can have a life cycle where man is an intermediate host between arthropods. And that's what happens when you're not out in the wild. This table has a lot of information. It basically talks about a lot of viruses that can cause encephalitis and are passed to us through mosquitoes. You can look at the reservoir, which is usually other animals such as birds or horses, and then you can be familiar with which viruses cause which disease and where they happen. This is going to be in the text. It's not particularly high yield, as long as you understand that if you could recognize some of these viruses and what they do, the main pattern will be helpful. Toga viruses include rubella virus, which is an envelope over an icosahedral nucleocapsid. It's non-segmented, it's positive sense RNA, and it replicates in the cytoplasm. Man is the only host for toga virus, and so the virus is spread by an aerosol route. The pathogenesis includes infection upon our respiratory tract epithelium. There it replicates locally, causes a viremia, and can spread to other tissues. The clinical findings include what's called 3-day measles. You have a low-grade fever, you have a sore throat, then you have posterior cervical lymphadenopathy. Then you get the onset of an erythematous maculopapular rash. It begins on the face, lasts about 12 hours to 5 days, approximately 3 days, and you can have associated arthralgias. Complications include in utero infections where you get deafness, congenital heart defects like a persistent ductus arteriosus or a ventricular septal defect. You can have CNS effects like microcephaly, ophthalmic problems such as cataracts and chorioretinitis, intrauterine growth retardation, thrombocytopenic purpura, hepatomegaly, and splenomegaly. You can also get progressive rubella panencephalitis, which develops in the teens, and you can get death within 8 years. So this is a lot like subacute sclerosing panencephalitis, which you get after measles. These two diseases you'll need to think of together. Lab diagnosis is often by serologic testing and viral isolation. The treatment is supportive care. To prevent it, we give an attenuated live vaccine. Question. An obstetrician sees a pregnant patient who is exposed to rubella virus in the 18th week of pregnancy. She does not have any history of rubella vaccination. The best immediate course of action is A. Terminate the pregnancy, B. Order rubella antibody titer to determine immune status, C. Administer rubella immune globulin, or D. Administer rubella vaccine. So the important thing is that if the mom has never been exposed, then you'll need to treat her, and maybe we'll think about terminating the pregnancy depending on the conversation with the mom. So the best thing to do is to figure out if she has antibodies to determine her immune status. Perhaps she got immunized before and has partial immunity, and that'll protect the baby. Next question. The serum of a 3-month-old with congenital rubella is most likely to show which of the following. So we have a 3-month-old child who got rubella congenitally. So A, fetal IgM against the virus. B, fetal IgG against the virus. C, fetal IgM and IgG along with maternal IgE against the virus. Or D, maternal IgG against the virus. So if the baby gets it congenitally, it means the mom had a new infection. So mom has IgG, which she passes to the baby. The baby is exposed and also makes IgM and IgD. So the answer is C. Next question. A pregnant 19-year-old female developed a faint macular rash over her face, neck, and back in her first trimester of pregnancy. She subsequently developed minor stiffness in her hands and knees, along with posterior auricular lymphadenopathy. She never received any prenatal care, and subsequently a deaf baby was born. Cord blood would most likely show antibody against which of the following viruses? So this is similar to the previous ones. We have somebody with a rash over the face, neck, and back. They have minor stiffness, and they have posterior auricular lymphadenopathy and a deaf baby. This is rubella, and it's a very sad story. Eastern equine encephalitis is a toga virus. It's transmitted to humans and horses, but it's maintained in birds, transmitted by mosquitoes. Incubation is 4 to 10 days, and you get the sudden onset of fever, general muscle pains, headache of increasing severity. You can get seizures and coma. Western equine encephalitis is very similar. It's usually seen in the 1st of June or July. It's asymptomatic or presents as a mild nonspecific illness. The encephalitis has a sudden onset of fever, headache, nausea, vomiting, anorexia, malaise, altered mental status, weakness, and signs of meningeal irritation. There's a 3% mortality rate. Flavivirus and bunyavirus are additional zoonoses that we need to talk about. The flavivirus spread by a mosquito vector. They can affect humans and birds, and it causes dengue fever, yellow fever, including West Nile and St. Louis encephalitis. Bunyavirus causes fever and encephalitis. Hantavirus is a member of the bunyavirus family. It can cause a pulmonary syndrome with fever, vomiting, pulmonary edema, and respiratory distress. And it can cause it's caused by inhalation of aerosolized secretions from the common deer mouse. St. Louis encephalitis is a flavivirus. It's a common mosquito-transmitted human pathogen. Less than 1% of infections are clinically apparent, so that's not a bad one to get. It often shows up as a simple febrile headache. You get aseptic meningitis, and you can get meningoencephalitis. West Nile encephalitis is also a flavivirus. It's a common mosquito-transmitted human pathogen. Less than 1% of infections are clinically apparent, and the incubation is 3 to 14 days. You often get mild symptoms such as fever, headache, and body aches. The skin rash is on the trunk of the body, and you get swollen lymph nodes. You can have a severe infection with West Nile encephalitis, including headache, high fever, neck stiffness, stupor, disorientation, coma, convulsions, tremor, muscle weakness, and paralysis. Yellow fever virus is a flavivirus. Mosquitoes transmit this disease to humans. The natural hosts are monkeys and man. There are urban and sylvatic cycles that we talked about previously, and it causes a severe systemic disease. You can have hemorrhages, and you can have degeneration of the liver, kidney, and heart. There is a live virus vaccine that we give to people at high risk. Cross encephalitis is formed by bunyavirus. It's a nonspecific summertime illness of fever, headache, nausea, vomiting, and lethargy. Unfortunately, you can also get severe disease if you're less than 16 years old. Seizures, coma, paralysis, and a variety of neurologic sequelae. Dengue virus is a flavivirus. Mosquitoes transmit this to us, and the natural hosts are monkeys and man. Again, we have an urban and sylvatic cycle. Dengue fever is also known as breakbone fever. You get the acute onset of a high-grade fever, a frontal headache with retroorbital pain, myalgias and arthralgias, and a maculopapular rash. Dengue shock syndrome happens when you get reinfection with a related strain. Questions. While in Costa Rica, a 30-year-old scientist developed fever, photophobia, myalgia, jaundice, and hematemesis. The most likely pathogen is, so we have somebody who's 30, they have this specific onset of symptoms, and so let's look at the answers. Measles is not going to cause any of these things. Hepatitis B might cause jaundice, but you shouldn't get hematemesis from it. Dengue virus also shouldn't give you hematemesis, and so yellow fever is the one you're going to think about. Yellow fever can be prevented by a 17D vaccine. We talked about this being possible with a live attenuated virus vaccine. Next question. A 30-year-old man, while on vacation in Jamaica, developed fever and severe pain in the back, head, muscles, and joints, as well as an erythematous rash. He describes the pain in his joints and bones to be extreme and severe in intensity and almost feels like his bones would break. His travel history indicated that he might have been in an area infested with mosquitoes. His most likely diagnosis is... Well, if the question stem is going to tell you that he has break bone fever, you ought to think about dengue fever, which is going to be choice A. Some other things like lymphocytic choriomeningitis are not going to show up with the joint pain and the bone pain. St. Louis encephalitis is often much less severe than this. Malaria is going to show up with a completely different presentation. So dengue fever is what you're going to have. In Module 36, we talked about the arboviruses, or different zoonoses. We talked about bunyavirus, flavivirus, and togavirus. They cause a number of different fever disorders. You've got encephalitis from the eastern or western equine sort. You've got St. Louis encephalitis. In each of these, you have a common system where an animal is infected, transmits the virus to us via an insect vector. Being familiar with this group of organisms and viruses and the diseases they cause will help you to get the test points you want. Next up, we're going to start our section on retroviruses in Module 37.